Yang kami hormati semua peserta guest lecture pada pagi hari ini, juga tentu saja para pembicara, moderator, dan para senior semuanya, Prof, Dokter sekalian, juga kepada Ibu Ketua Departemen, Dr. Trirana Ningsih, dan seluruh tim. Terima kasih banyak. Pagi hari ini tidak lupa kita selalu mengawali kegiatan kita dengan syukur bahwa kegiatan pagi hari ini bisa kita laksanakan dengan situasi sekarang. Dan juga sekali lagi bahwa kegiatan guest lecture itu kan kegiatan yang rutin ya kita adakan, merupakan kegiatan rutin dari Departemen dan Program Studi Patologi Klinik dan Kedokteran Laboratorium FK-KMK UGM. Ini untuk yang sekian kalinya dan pada pagi hari ini mengambil topik yang sangat menantang kalau istilah saya ya, karena trombosit atau platelet merupakan atau sesuatu yang masih misteri gitu kata Prof. Usi. Tidak hanya sekedar tanda petik untuk kepentingan pemeriksaan di rutin, di darah rutin, kepentingan atau perannya di hemostasis, tetapi ternyata juga punya peran di area-area yang lain, di area imunologi, di area keganasan, di area yang lainnya yang semuanya ternyata menjadi sangat luas, termasuk juga peran di infeksi. Tidak hanya itu, tetapi bahwa masih banyak hal tentang trombosit yang perlu kita eksplor, dan itu tantangan ke depan karena tentu akan membawa dampak yang bermakna untuk khususnya di bidang kita di laboratorium. Sekali lagi kami menyampaikan terima kasih kepada eh, para pembicara, eh, Dr. Prakas Bakwandas Sufasya, kemudian eh, Profesor Dr. Usi Sukorini, dan nanti moderatornya Dr. Dani. Terima kasih banyak. Dr. Prakas, welcome to our guest lecture event. We sincerely thank you for taking the time to share in this event. And we hope that your lecture will surely enrich our insight, especially on platelets. Thank you again for your contribution to our event. This event is dedicated not only to our student but also all of our colleagues around Indonesia. So again, thank you so much. Juga terima kasih kepada PT Horiba Indonesia yang telah banyak membantu kegiatan ini, mensupport kegiatan ini. Dan terakhir, terima kasih juga kepada Dr. Ratna, ini pimpinan lead untuk kegiatan beberapa hari terakhir ini. Terima kasih banyak beserta seluruh tim, teman-teman residen, terima kasih banyak sehingga kegiatan bisa berlangsung dengan sangat baik. Mudah-mudahan ini juga akan diteruskan dengan kegiatan yang berikutnya. Saya kira itu saja mungkin yang bisa kami sampaikan. Sekali lagi terima kasih, semoga bermanfaat. Dan dengan mengucap Bismillahirrahmanirrahim, maka kegiatan guest lecture pada pagi hari ini secara resmi kita nyatakan dibuka. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih Dokter Teguh atas kata sambutannya yang sangat menginspirasi. Demikianlah acara pembukaan guest lecture Platelet Maximizing the Potential Simplifying Hemostasis in Your Lab. Bapak dan Ibu dokter yang berbahagia, untuk mengefektifkan waktu, kita masuk ke pemaparan materi pertama yang akan dipandu oleh moderator Dr. Rahmat Dani Satria, MSc PhD, Spesialis Patologi Klinik, Subspesialis Hematologi Klinik Konsultan. Adapun kurikulum vitae beliau telah tertampil pada layar monitor. Saat ini beliau adalah staf pengajar di program studi patologi klinik dan Kedokteran Laboratorium FK-KMK UGM. Kepada Dr. Dani, kami persilahkan.
Okay, thank you, Dr. Chitrakia. Ladies and gentlemen, Bismillahirrahmanirrahim. It's my great honor today to introduce our guest lecturer, Dr. Prakash Sufasya. Dr. Prakash completed his medical education at Maharashtra University of Health Science in Nashik, with further training at College of Physician and Surgeon in Mumbai, and he held several key positions in the field of medical diagnostic and scientific affairs, including medical and scientific officer at Horiba in France, manager and scientific support at Horiba, India, and later as head of scientific affairs and product management. Currently, he serves as the international marketing scientific and medical officer at Horiba Medical. Okay, ladies and gentlemen, let us warmly welcome to Dr. Prakash. He will deliver his guest lecture in the topic of platelet, maximizing the potential, along with case studies related to hemostasis. Time is yours, Dr. Prakash, please.
Okay. Thank you so much, and very good morning to all of you. Thank you for giving me the opportunity, the entire UGM team, Dr. Ratna, Dr. Regia, Dr. Danny, and thank you for your warm introductions. So I will try without wasting time because it is an online session. It takes a little bit of technical challenges, as we all know. I would love to be on an offline face-to-face discussion and interaction, which is much more helpful to understand. So I will straight away move to my presentation. Uh, so I hope my screen is visible, right? Okay. All right. So once again, thank you. Thank you all of you for joining and getting up so early and trying to understand the most difficult topic of our hematology. So as we say, it is platelet. We need to understand how platelets can be used to its maximum potential in its technical value as well as the medical value. So one thing is very important that before we talk about any parameter in hematology, we should also know the background of that particular parameter. So that particular parameter is platelet, which is, we all know, it is the smallest of the cell population in entire complete blood count. It is smaller than the RBCs. So it is very difficult for to sometime to even look by eyes, and then it becomes a challenge also on the technical aspect. So for that matter, we will try to see how it is possibly to look around everything about platelets. So I always say there are some myths around, there are some truths, and there are some facts. So myths, we need to understand what are these myths and how do we try to avoid and use it in our routine practice. Truth, that means how do actually these particular parameters behave, and the facts are nothing coming from my side. My experiences is just an added on, but there are a lot of literatures that we need to also see when we try to give an understanding about the platelets. So platelets, as we all know, it is thrombocytes. This is an outline of the entire presentation, which will be, so I'll talk a bit on the platelet count because this is something very necessary, how the evolution of the platelet count has been there right from the traditional to the new challenges, what we see and how do we overcome. A bit on platelet pathology because we should know when do the platelet are changing in the field. I mean, whenever there is a disease or an infection, how do platelets actually play an important role in our day-to-day routine practices. Then something I would like to put a focus or a highlight on what we nowadays want to know about something called as large platelets. So what are these large platelets, or sometime it is called as young or sometimes reticulated? What is the actual nomenclature which we need to use, and what are their role in this day-to-day routine infections? And how do we know this? Because as the value of the large platelets in our day-to-day routine. So I have two cases to discuss after this end of the usual presentation. Then we can know how exactly this platelets can be helpful. So this is a question for all of you. Anyways, you can just keep it on your mind because it is basically like more to have as an interaction or something. So we all know there is uh, platelet count is always a challenge. I am happy with till my cell counter is giving the right platelet count, but I will not be happy if it is not giving the right count, or sometimes it gives you a lot of flagging, or sometimes the platelet count is less, and then the worry starts. So the second question is, do we need to actually rely on the platelet count, which are done on the cell counter, or is it like I need to rely on some other technologies? So we will try to see how we can answer these queries. Before that, as I told, we need to understand about what exactly, why are we so much worried about the platelet counting? So long back, an Italian pathologist, Giulio Bisorio, he described the platelets as the corpuscles, because in the actual terminology for any particle in the blood or the blood cell components are corpuscles, right? Red blood corpuscles, white blood corpuscles, and the platelet. Platelets, as I told, they are very small, but they are very effective. Why? Because they play a crucial role in coagulation and thrombosis. We will try to see one of the case where we try to understand how platelet is changing in a problem which is associated with a thrombotic pattern or in thrombocytopenia along with the coagulation problem. So this is a very simple presentation. I mean, the photograph which is showing platelets, red blood cell, and if there is any injury is basically there is always a plasma leak, and the blood vessels are always sometime, not sometime, but most of the time they are affected in cases of any infection or any injuries. So activated platelets are the first one. They are the first responder for formation of a thrombotic clot or thrombosis, and then the coagulation follows. So here we try to understand how platelets have a very, very important role in thrombosis and coagulation. So this is just a simple revision of our how these platelets are formed, what we call as thrombopoiesis. So megakaryocytes, which is a very large cell, it is one of the biggest cell in the bone marrow. And then when it goes through the process of thrombopoiesis, the size keeps on decreasing, and ultimately they become very small when they come out in the peripheral blood. So interestingly, from a very large size to a very small size, and this small size is very much of a problem sometime. We try to understand each and every problems on this. And as we have understood, the most important role is the primary hemostasis. So we can understand if there is a genetic problem of platelet where they are not functional, or they are less in count, or there is a disorder in the bone marrow, or if there is destruction. So we will lose on to the primary hemostasis. This is actually a very normal platelet count, which we all are using. This is the reference range coming from the international literature. So I always keep on saying, when you validate your or verify your instruments at your place, please also try to do a normal range verification, which is what I think was very nicely described by Dr. Ratna on the Horiba Scientific Seminar, where on 30th of August. And in the verification process, we should have a normal reference range verification of that particular population, because we try to see, okay, if the platelet count is below 50,000, 20,000, 10,000, the question is, do I transfuse or not? So we'll try to see what is exactly this question, which comes from the clinical side, because they ask your suggestion in the pathology department. Should we transfuse or should we wait? We should also know the half-life of these platelets. They don't stay for so long like RBCs. Like RBC stays for 120 days, but their half-life is around, say, 8 to 12 days. Maximum, they will stay up to 10 days. And the size definition, this becomes very important nowadays, because cell counters or what we also used to say 50 years back, they are particle analyzers. So these are nothing but the particles as described earlier. They are small particles, but they are in the form they are in the liquid state of blood. So this, you can just imagine, the size is too small. So it becomes a challenge, and for some of the technologies to capture it, but in some conditions also it becomes a challenge. So we should know what exactly the definitions we are using when we practice or give the normal reference range, or when we discuss about the platelet problem. This is just a simple definition. I mean, this can change from practice to practice what do you call actually as thrombocytopenia. But idea is, how do we get the thrombocytopenia? Is it like a central right from the bone marrow problem, or it is peripheral? So these are the two important aspects of having a problem with thrombocytopenia. Most of the time we are not worried much about thrombocytosis, because we feel it is still very specific to few of the problems. We have always been studied in the medical schools that platelet looks gray purple particles when you do a peripheral blood, and we should also know about what exactly the ultra changes are. So platelets are enucleated. Basically, they don't have a nucleus when they are in the peripheral blood. They are mostly the cell organelles or the granules. These are very important aspect, because these granules, their absence, presence, their content depend helps in the role of thrombosis. So we should be very much aware about the platelet ultrastructure and the composition. So this should be kept in mind that platelet don't have nucleus when they are in peripheral blood as the RBCs. And all the platelets who are there in the peripheral blood always have an RNA, because they function on RNA. As the cell organelles mostly have an RNA for their transcriptions and working. And RNA is not just in young platelets. I'll come to this point when we what exactly is young platelet. So please keep this in mind, because this is a question and more of the technical challenges, and also there is always a debate between in the medical or pathology forums that what should we call as young or what should we call as large and things. So this is just an ultrastructure. And here I have shown this picture coming from ultrastructure. Whenever platelets are at rest, they are very happy. They are round structure, very small. The moment they are active, if you can see, the cell organelle changes and they changes their shape, so that they become active and they start working. So we should also know, when we see under the microscope in a patient where there is a stressful conditions like fever or any infection which is caused platelet to active, they change immediately in the shapes. We don't have ultra microscopes or electron microscopes in our practice, but if you try to see it carefully, on the peripheral smear they become more dense, they become more darker, they become more increase in numbers or the granules. But this has to be kept in mind. Now, coming to what exactly are we looking for? Is it a diagnostic channel or a technical channel? Because we have to count on platelets. Okay, it is very important to see how platelets are actually helpful in our routine practice. We can see they are more like a band-aid at first level. So they always say you can count on us, but yeah, internally it is good, but how do we actually convey this message of that there are good platelets and you don't need to worry to the patient or to the clinical sites? So we need to know about the clinical value or the actual need for the platelet count. So these are a few of the conditions where we see in the routine basis in our practices that platelets basically they try to change, as these are all stressful conditions, or sometimes they are normal but they are the inherited disorders. So we need to know more commonly like fever, weakness, infections, malignancies, intensive care monitoring, because it is very important. This is one of the parameter in intensive care where we decide on the critical conditions of the patient. So these are few of an important part. And also in transfusions, because we do transfusions at some level and then we try to see how these platelets are functional. Then this is the actual thing what we get it. It's like more of a medical value over a technical value. But when you are working in the lab, these are few of the things which we always try to see when you function as a lab manager or as you are operational manager for the lab being a doctor. So you are always asked these questions in the lab in general related to your diagnostics. So what are we actually working for? Are we giving a medical value, or are we giving some quick decisions for inpatient optimization on the technicality, the result qualities and effectiveness? But here, first of all, the question as we relate today is more on the medical value, because everybody looks into a pathology report for an accurate decision or the accurate number. So this is the most important challenge what every lab would be facing in the world. And we try to give a lot of like result which are of the quality where the doctors can take a reliable decisions, and rest all follows as a management part. But here, as I was talking, it is more diagnostic or technical. So let's see how does we solve this. So one more, because you can you can talk to your clinical doctors in intensive care, in medicine department or surgery department. What are the local guidelines they follow for platelet transfusion? What are the recommendations when they would like to do a platelet transfusion? So there would be local recommendation from the blood bank associations or transfusion community. But I tried to pull out one of a recent literature on platelet transfusion, and it's a very good publications where it gives you international clinical practices and guideline, which is followed across the globe in terms of platelet transfusions, which is where we want to be aware when to give a transfusion or when not to give a transfusion. So these are the few of the recommendations what you get on platelet transfusion. So there are strong recommendations, there are some conditional recommendations. So we need to convey this message to our clinical department with the help of this literature, that these are few of the stronger recommendations where we need to actually think about the platelet transfusion, or otherwise we can still rely on the platelet data what we are getting for the patient. So you can see there are recommendations and guidelines for platelet transfusions, when it has to be transfused, and the evidences when the severity, whether it is moderate, high, or again moderate. So accordingly, the decision for holding or doing a platelet count can be done. You can go through this paper, which is available on JAMA. Now coming to the challenges, because we all work in a laboratory, okay, and we should know what are the challenges, what we see, or what are the right tool of doing the platelet count. So historically, nobody do it nowadays, because now we have all type of technology. But it is always good to know how do we used to do in medical schools when we were young medical students for doing our basic medical education. So we have done, everybody has pricked their finger and have done this analysis and trying to look their own cells. And we used to say, okay, this is the cells, what we see. So if you can see, there is a big platelet and there is a small platelet, or say the normal size platelet. So this is a traditional way of doing a Neuvas chamber and the microscopy. Uh, if somebody asks you a question, what is the actual, say, gold standard? When we always say there is always a reference or a gold standard technology or a reference method for platelet count. So it is still the International Council for Standardization. It is by ICSH, and this works on the principles of flow cytometry, which is where you can sometime try and doing the validations and verifications of the platelet. So flow cytometric platelet count methods are basically important just for your verification, or basically for as a manufacturer like Horiba, we try to do it for our validation of our instrument when they are in the development stage, because we want to be very sure that we are compatible with the international standards, and we have already done it for our optical platelet in some of the studies, and they are found to be very good in on our systems. Now coming to the most important and the basic concept of automated platelet count, which everybody is using across the world, which is called as the Coulter method. And we all know how Coulter method works. So these are basically nothing but cells which are passing through a diluted solution through an aperture, and an electric current is flowing. The cells pass through the current and changes, gives you signals. Like these are the signals of the impedance signals here. You can see these are the signals which are getting captured. So you have the sample here. There is an aperture, and then there is a pulse generation. From pulse generation, you have display of the pulse. These all pulses are cumulated, and then it is transferred into a numerical number as per the height. So platelets are smaller in size, so of course they will have a smaller height than the RBCs, because RBCs are a little bit larger than them. And these are the number of cells, and then finally you get a beautiful platelet histogram. So this is the first information coming from the cell counter, that this is the platelet information, or this is how the platelet is been placed. Okay. So we should be aware about this. We should always see a platelet histogram before we see the number, because this is very important to understand on the cell size and the distribution of the platelet, and it can give you a lot of information at the first time. So what exactly hematology analyzers are doing with the platelet? So there is an evolution of hematology analyzers since like last 15, 20 years, and things have changed. So we have got platelet count, which is the usual one. Then we have mean platelet volume, like we have hematocrit for, or say packed cell volume for RBCs. We have PDW. It is something similar to RDW of red blood cell. It is platelet distribution rate. Then you have platelet crit. Then we have platelet large cell ratio. So these are some important index which are nowadays present in the routine 5-part or say newer hematology analyzer. And we should also know how they come because they are not directly measured. They are all calculated parameters as red blood indices, as we see MCH, MCV, MCSC. So it is something on the similar lines because they are all particles at the end of the day. So we can identify a few more parameters. So like platelet crit is your mean platelet volume into platelet count. Then you have MPV, which is also an indicator of change in the size indirectly. We have platelet distribution width where we can see anisocytosis, that is basically indicative of platelet anisocytosis and which is important in some features. When we have platelet large cell count and we have platelet large cell ratio. So these all parameters, how we'll see how we can maximize the utility of these parameters coming from the technology. Because if I see it on the microscope, I will only see the size of the platelet and the color of the platelet. We cannot identify what index and what indices has been changing. So these are the technical parameters which I was talking about, and you can see it on how they are depicted on the histogram. Okay. So these are the routine parameters. You can have an understanding of this. You can take for your reference that these parameters changes in associated with few conditions. I have only put the parameters which are usually or nowadays available on the cell counter. So very common conditions like dengue, where you have destruction of from platelets peripherally. So what is elevated, what is decreased? So this is not an 100% thing because everything in cell counter happens in relativity. There is no absolute because one parameter changes, other will also change, or they will try to do a difference. So whenever you want to practice this, you actually try to find few cases of the same type, and you try to see whether they are actually functional or not. So that is why I have one or two cases to show how these parameters are changing in certain conditions. But for our purposes, where we are using a routine 5-part cell counter, we have this parameter. We can actually convey this information to the doctors that we can still wait for some time to transfuse, or the criticality of the conditions can be assessed with these platelet parameters as well. But as we all know, we all use technology since like hundred of years, but there are always an evolution and there is new innovations in the technology. It is not because the previous technologies are bad, but the new things are available and we can overcome limits. So accordingly, platelet impedance or the Coulter principle have its challenges because as it is a particle, small particle, we can also have microcytic RBCs, fragments, or some large platelets which can be missed. So we should know how an histogram is important. This is a normal platelet histogram where you have a variety of platelets, right, from the normal or the small platelet to the large platelet. But this in between portion is very important to understand because these are the routine RBCs. If their size changes, they will start be getting counted into the platelets, and we can have a falsely high platelet count sometime in platelet microcytosis or aggregations and things. So here are a few of the conditions which can have an interference. So we should also know as a pathologist, it is not only about the microscopy, but what is the machine trying to say on giving an alarm or a flag or when the histogram changes. So we should also be aware about the limitations or the conditions which can interfere the platelet count. So this is how why I was saying why histograms are important. So this is something very basic understanding. When you have a size issue, when I say size, it is mostly the large platelets which are not getting counted and the histogram is not falling. It is going up and it is going in an area where RBCs are also getting counted. So we should know the pattern of histogram of platelet rather than the number of histogram, and then probably you can follow it. This is a morphology issue. So if you can see, this is size issue, this is morphology where you have a lot of different type of platelets. So we have platelet PDW, which in where you can see variations in PDW, you can also identify there is platelet anisocytosis, which is a very important feature of I always put it like if you are having a platelet anisocytosis or PDW, that means the bone marrow is trying to produce a lot of different platelets or is just trying to compensate, and which we can see it on smears, sometimes small, sometimes big, sometimes fragments. So the histogram is actually a true indicator of the platelet, the analysis of the platelet. But in the meanwhile, as I was talking, there are a lot of evolutions which have happened in platelet analysis to overcome the culture challenges. So the culture challenges, or say the challenges of interference, we have impedance, then we have optics, and now we have impedance with optics, wherein even Horiba have a system called as an 2500 and 1500, which works on the principle of optical extension, which try to give you an understanding on the optical counting of the platelet, which are the true platelet and which are the interferences. Okay, so we should always be following and understanding. So till that, this the last slide, it was all about how a platelet is getting coming into the peripheral blood. What are the type of platelet what we can see, and how the challenges are getting overcome in the field of when we have interference. Now, the question is always today for us in the pathology community is like, is it only about the platelet count? Because platelet count is high, low, or it is normal, But now what we have understood with the evolutions of the new technologies, we have also understand that the size of the platelet is also a very important feature nowadays, because in few of the clinicians have or the clinical department, we have tried to put the knowledge to them that the platelet size can also help in recovering the platelet, recovery in terms of some peripheral thrombocytopenia. So these are again two things, because it is the answer of having is it the size issue about platelet count? No, we know the technical challenges with the cultural principle, but most important now is what we can help the medical community or the clinical departments is the platelet aspect or the medical aspect. We can predict the platelet recovery in few cases of thrombocytopenia. We can also understand the mechanism behind it, and we avoid invasive procedure like transfusions, because sometimes patient can have transfusion reactions rather than having any complications due to thrombocytopenia. So we should always understand the platelet in its overview. When I count it, is it the counting problem of the machines? Why and how we can overcome? And also how the size variation today is becoming an important aspect as new indicators for platelet recovery. So I always think we should be supportive, and we are always being in support with the medical community. So this is just an understanding about a thrombocytopenia, what we generally see. So it all starts if I have a low platelet count, what exactly I'm dealing with. Is it a peripheral destruction or is it a bone marrow failure? And accordingly, we can see the development of young or large platelets. So these platelets are always being present in the peripheral blood. And in the bone marrow, these are the changes what we see when we have a problem. In peripheral destruction, there can be an increased megakaryocyte. Nobody do a bone marrow examinations in these conditions. Okay, these are all can be indicated on the lab numbers what we get from the coagulation, or we can see our peripheral blood. But whenever there is a bone marrow failure like aplastic anemia, or there is a bone marrow shutdown due to chemotherapy, then there can be decrease. But nobody do a bone marrow examination in these conditions actually, unless and until it is required. So we always rely on the machine or the hematology analyzer values and our experience and knowledge of looking into the microscopy, like and the peripheral blood. And the other aspect is we talk very less about thrombocytosis, but thrombocytosis cannot always be a clinical problem. Like we have a lot of clinical problem, infection, inflammation, damage, non-malignant disorders, and very important essential thrombocytosis, which is malignant conditions, and other is like followed by polycythemia, CML, and primary myelofibrosis. But important technical challenges, the interference of the microcytes and the cystocytes. So before giving a understanding about thrombocytosis, we should differentiate between a medical and the technical problem, which can be the technical problem can be easily judged and assessed on a platelet histogram on the cell count. So this is a thrombocytosis where there is a variety of platelets. They are dark, they are big, they are small. But again, this is a true thrombocytosis where I can say it is more of a medical problem over a technical problem. So technical problem will be judged on the platelet histogram, whether the medical problem can be seen more on the peripheral smear. Now, we should also know few terminologies, like there is a terminology nowadays used like platelet thrombogenicity. So what exactly it is? So it is said that the platelet size may not always correlate with the platelet age. That means we try to see young platelet, large platelet, or things what we say. But it is also under a steady state, we also get a platelet production because bone marrow is a factory. It keeps on producing and reducing. So this always happens. So we should always know what exactly are we dealing with. So large platelets always secrete more granules, which have more of ATP and ADP. Large platelet aggregate faster because they have much more larger granules in terms of the smaller ones or in terms of the normal ones. Then it is basically thrombin-induced aggregation. This is a process and part in hemostasis because thrombin is something which is trying to excite the aggregation of the platelet, and it is like more compared to the small fractions which are independent of this. That this means the aggregation can also happen with the small platelet also, not only with the large. So means whenever there is a problem, every platelet will start going in. So we always try to understand, is the platelet size giving you any idea about the underlying conditions, you know? So these are few of the conditions. And by looking into the platelets, we cannot assess is it a mature or immature. And the problem is there is nothing called as mature or immature platelet. Immature means it is small. It is an English dictionary word. Immature means non-functional. But literature says when you have large platelets like this, what you see, it is going to give you more reactive or they are more adherent to the thrombotic part. So these cannot be immature ones. These are very important. So the terminologies have changed to the young platelets. So this is an interesting article by Perpectin, which is almost like I'll say 40 years back. He has written this and he has already told this hypothesis of large platelets are actually young and small platelets the older subpopulation. So it is basically from when you're it is like when you see a blast, it is more of an immature type of a cell, which is an early cell which is coming out from the bone marrow. It is something similar. That means the cells which are more young would be showing a larger size over a small size. But the question is they can also be large and they are younger, but they can also be small. So they both have the similar type of fraction. They can be both can be reactive. So platelets have different physical properties. They are including the density and the size. And the literature, what we have seen, they say the large and the younger one both or the small size can have the similar type of reactivity. So this is a very important article. I guess everybody should read it. Whoever is uh, working in the laboratory medicine or in a specialized hematology or hemostasis lab, it is a paper of almost 20 pages and it has to be read very well because it shows a different role of large and small platelets in the scenarios what we see. So I have taken one point from the same article that increased platelet size has been regarded as a feature of describing a young and a more reactive subpopulation. And because it was not published in so long, now we can see there is whenever there is a change of the platelet size, which is given by mean platelet volume, there is also we can describe in different type of thrombocytopenia. So these are very important thing. And if you can see in this is not a older one. This article is just came in 2020, and they have described it as more young platelet, not as the immature platelets. So we should start calling them more younger or the larger platelets or not the immature ones. So this is a very old article which says almost a similar way that morphological changes, when they introduced, there were changes in the platelet size as well. So is it immaturity and the age of platelet we try to assess? Okay. So platelets in circulations, whenever platelets are there in the body, in the peripheral blood, they are platelets. They are not mature or immature. They can be small, they can be big, they can be giant. So we see morphological change rather than the age, because when I say immaturity, it is more related to the age aspect rather than the size aspect. So I always say whenever you have a new platelets, these are the platelet sizes you can see in certain conditions. And what we call it as immature could be something like this, which are the fragments, which are the protrusions. Sometime in the case of CML, you may probably see them very clearly that these are, there are in an extensive CML cases, you can see platelet fragments. So this could be the proplatelets, okay? This could be the protrusions coming from megakaryocytes. So these are basically something what we can call them as immature, but they don't have anything, they don't have any granules. They are not active. So whatever is active is the young platelets, which are the high density granules, what we see it on the smear. So this is just an understanding about do large platelets have a focus on thrombogenicity? Yes, they do have. But we should also understand, because I wanted to, as I was telling, it is myths, truths, and facts. So this is one of the myth which is there. It is not a biological process. It is more of a technology. When I say reticulated, in the body there is nothing called as reticulated or areticulated. It is how we try to see anything, like we stain the peripheral smear with the Leishman stain or or an MGG stain. The color are coming. Similarly, as we say, platelets always have an RNA, so they don't have any other component. So if I do an staining of platelet, I will have to use a reticulocyte stain, which is a supravital stain used for uh, tagging of RNAs. So the reticulated platelet is actually where the platelet are a little bit bigger and they are dense in their RNAs. So that is why they have the larger size, and probably these may also miss something is small, okay? And we cannot see them in as an immature or mature, but we see them as reticulated because we have added an reticulocyte and as a fluorescence, and we have done an analysis. So it is more of a technological aspect over a biology aspect. So we should also know the concept of reticulated platelet. It is more of an experimental analysis of a platelet. They are not reticulated because inside the body they just carry an RNA, okay, for their functions and granules and cell organelles. And to see them in higher component and large platelet, they will be more dense. So this is a literature review which you can see. I am not going into too much detail. It is there in the same article what I showed you. So that is why I'm trying to say, if you read the article on your own, your understanding would be more clear. So what is the retic actually which is used? It is basically the the component, the fluorescent part, which is thiazole orange, which is one of the gold standard reference method for automated reticulocyte count, wherein if you have a thiazole orange, it is basically going to give you more better analysis when you do an automated reticulocyte count. It is when I do it on the smear, we use the routine methylene blue or something like that. But here it is different. So this same methanol orange will also tag the reticulocytes, immature, the retics which are present from the nucleated red blood cell, and also the RNA component which is present in platelets. So it is all about the technical analysis happening in the machine. So we should have this question to be solved on our own. So this is a little bit of fact check. And as we said, this is a repeat of the earlier. They Platelets always have RNAs. So I always say the platelets have RNA. They don't have any other component. It is just the way you try to see it in the way you want to. So increased platelet size has been regarded as a feature of describing a young platelet, and they are more reactive. So size increase, more RNA. So you can see it on RNA analysis or say reticulocyte analysis. But we can also do how this young or large or reticulated platelet can be seen, you know, in the routine practice. So in humans, the analysis of reticulated platelet have revealed an overlap finding with large platelets. So whenever you do a reticulate analysis, so platelets are independent of platelet turnover, but there could be small platelets which are young also. Not necessarily they have to be large. So this could be missed when you do an analysis for reticulocyte platelet analysis only when we feel they are larger. So we have to do an analysis of all type of platelets which can be useful in this. So young platelet is equal to the large platelet, and reticulocyte platelet is nothing but a subpopulation of your lung large platelet. So the idea of showing that was basically when you see a platelet or you hear about reticulated platelet concept, it is more of a technology. It is not a biological process, because the large platelets are always having more dense RNA, but normal platelet also have an RNA. So these are the few of the definitions which you can see. So there is normal, there is large, we have giant platelets, and there are something called as macroplatelet, where you can see an isocytosis which can be depicted easily on say PDW. So these are a few of coming from again from the same from the journal. You can see what changes and what exactly is the change happening whenever the platelet is large. So this is very important. So prothrombotic mRNA profile and higher population of reticulocyte platelet. So the size is large. This is coming from the platelet fraction. So the the platelet fraction is larger in size whenever the RNA content is high. So basically, bone marrow releases more of a larger platelet than any other platelet. Okay. So how do we assess this medical value of the large platelet? And this assessment of the large platelet is basically due to an understanding about the values. Just a second. Okay. So we have a technical value where I want to assess the large platelet and understand them, and we have the medical value, which is of very much of an importance. So idea is we assess both on the technical ground as well as on the medical ground, because we want to convey to the medical department that we have this. Okay, so there is a correlation between the size assessment and the thrombogenic markers. So how do we see this as a thrombogenic marker? So PLCR is a very routine parameter in all the cell counters where we see this. And this is an article which we try to do it with immature platelet fraction and platelet large cell ratio. It is a very routine parameter. You don't need to pay anything extra. There is no consumption of reticulocyte reagent, but still it is shown a promising results, as it can be also an indicator for recovering thrombocytopenias. So platelet recovery, this is one of the case which we have done. There were 20 cases, and these are different patients of dengue where we try to just see the platelet count versus the PLCR. So whenever the platelet count is dropping, we can see the PLCR is increasing. That means it is giving a trend of analysis that PLCR will have an increased trend. That means the bone marrow is trying to produce more larger size of the platelet in whenever the platelet count is decreasing, which is again an indicator. If you can see at the last of this patient, the patient number 8, the platelet count when it has increased, the PLCR has dropped. That means it is normalized. So PLCR could be a good indicator for that matter. And there are a lot of articles where it says the utility of platelet indices in thrombocytopenia, not only the advanced parameters. Now a word about optical platelet. Everybody do an optical platelet. It is a separate analysis apart from platelet indices, and it is basically used whenever there are where large platelets or giant platelets, or wherever there is a higher PLCR or high PDW or MPV. But this is coming on a very larger systems or technology of hematology analyzers, but which can be also seen very clearly with MPV, PLCR, and PDW. And by microscopy, we can confirm whether there is interference due to fragmented cells or microcytes or large platelets. But this is a technology which can actually help and give a differentiation and give an exact count. So this is a technology what we call as optical platelet technology. It is in simple, it is more of refractive indexing. So refractive index of platelets is different than the RBCs, and this technology is able to give an differentiation between both the parameters, like because they both have a different refractive index, so they can be easily separated from each other. So this technology depends on the refractive indexing of different parameters, and the technology is called as extinction. Extinction is basically the loss of light, And from the same technology, we are also able to identify the large platelet fractions which gives an indication for the young platelets. So this is an example coming from our cell counter. So if you can see, this is used for platelet interference whenever there is, because of platelet cystosis, this is an alarm. This is a star mark where the platelet is high, and you can see the interference. But if you see the optical platelet, there is a separation between RBCs and the platelet. So in this, it can be easily utilized, optical platelet count versus your platelet. So 273 is impedance where there is a star, but in optical platelet, it is 250. So that means the separations from optical platelet can be easily seen. And this is thrombocytopenia because in some time we try to understand the reliability of the count. So the platelet impedance is 14 and optical platelet is 25. So this can also be understood because whenever the count goes low, there could be particles which can interfere in impedance, or they cannot be. And if the count is if the size is very small, then it can be a problem. So optical platelet can give you a more reliable count when we think about it. So thrombopoiesis and large platelet fraction, basically I'll try to say that they have an indicator for thrombopoiesis. This is something which we try to identify on our higher technologies called as large platelet fractions. It is nothing but an additional understanding on the optical platelet extension that can be identify the young platelets. So we have an understanding about that large platelet fraction corresponds to the platelet subpopulation when the size is going beyond 20 femtoliters. So that means we can understand on this. So we have these cases of large platelet fraction. Again, it depends on the refractive indexing of the platelet and RBC. So this is the normal LPF. This is the low, where the count is low and something like in bone marrow problems or chemotherapy. And you can see this is the large platelet fraction where the platelet count is coming from here, and there are lot many large size platelets, and they are getting separated. This is RBC and this is the platelet. So in high LPF would be seen in few conditions of thrombocytopenia. These are the evidences which can be shared by our team to you for more reading on LPF, how it is worked. And this is the poster which we presented in an international conference, and how it is different from the other technology where they are doing reticulated platelet and we are doing non-retic analysis, but we are trying to identify the large platelet fractions in all capacity. So we also have a population of the small as well as the large in the large platelet fraction. So this is a complete picture of a cell counter which have all the characters of all the parameters of the platelet, right from like platelet, MPV, PCT. So the idea here is don't only see this. Whenever we try to see, we try to see the platelet histograms, which are very important, and try to understand the alarms which are given by the instrument. So these are the flags and alarms where you can see abnormal MPV, abnormal PDW, whether it is cystocytes or macroplatelet. We have this slide understanding, and we also understand the platelet indices with its analysis. So all this together can give you a better understanding on the platelet. So this is a final understanding of the platelet topic, what we try to cover. So we should all know that platelets have RNA. Okay, the young platelets are more large and they are more reactive. Reticulated platelets are large with dense RNA. Hematology analyzer, this is very important. They quantify. Okay, they don't do any functional assessment. So they only look for the biophysical property, whether it is small, big, different shape, but it doesn't give you a functional analysis. That for that we need to do functional assays of the platelet, which is not the job of a cell counter. And whenever we have a young large platelet population, which we should think about that platelet is going to recover. And in routine cell counter, we have PLCR, MPV, PTW, and bigger cell counter along with LPF can give the idea about peripheral thrombocytopenia recovery. Ultimately, as we all are pathologists, microscope cannot be taken away from us. Okay, so these are the best friend and the guide to look and finally analyze. So platelet indices are valuable tool. We should use it with its capacity, knowing the physiology, pathology, understanding about small platelet, large platelets, understanding about the limitations of the traditional technology, understanding about the problems where we can see. And when we integrate platelet indices into routine practice, which is what we try to say to the clinical departments, that okay, this is changing, this is stable, so probably there will be more valuable to our diagnostic procedure. So there's are few literatures, and this is Q&A. I think uh, I will jump to the another topic uh, if I can. Okay, hopefully I mean that if there is uh, any question on platelet, or shall we have later? Dr. Regia?
Okay, Dr. Prakash,
Yeah.
you can continue your lecture. After the
Okay.
two lecture finish, we will continue with Q&A question. Okay, thank
Oh,
you.
hopefully I have time, Dr. Denny.
Okay.
All right. Thank you. So we understood the platelet in its hematology aspect. We understood when this platelet is going to be a challenge on technical, on medical ground. Now, this is something not completely related, but this will give you an understanding about hemostasis. Because I know coagulation or hemostasis is always a gray area in a lab where we try to understand a lot on all the aspects. Okay. So I will try to summarize the way I can, because it will give an understanding about how the coagulation uh, system works. So we should know a little bit about the coagulation problems. So we have an introduction on the same challenges, what we face, need and recommendation, technology choice, choosing, and of course, we should always know about the anticoagulation. So I have case on thrombosis as well as the platelet association, which I will try to put it a later. So hemostasis and coagulation assay, which is very difficult topic sometime to understand. It is very volatile topic. So hemostasis is basically a complex interactions of vessels, importantly platelet and the coagulation protein. There are specific tests available to evaluate. We have platelet functions, we have coagulation proteins, and then we have inhibitors and fibrinolysis. Most of the time, we stop at the thrombotic angle. We don't see much about fibrinolytic systems coming ahead. So this is an understanding about the hemostasis. This is like when you have an injury, you have vasoconstriction, activation, then there is a cascade, and this cascade is very, very complex sometimes with the coagulation protein coming into the picture. And yeah, there is a mechanism called as antithrombotic control, where it should not only keep on clotting. There has to be a stoppage to this clotting at some time. So platelet have an important role again, and platelet with von Willebrand factor and fibrinogen forms the platelet plug. So this is in association with this thrombin-induced von Willebrand factor and fibrinogen. This is the cascade, and finally the fibrinolysis and clot degradation when the job is done. So we have always been learning about okay, we have been always learning about the coagulation cascade. Yeah. And this is very complex, and I always say we have to start and reverse numbering. We should start from say factor 12 to factor 1. So this is very easy way of understanding the clotting. So the clotting factor comes from 1, 2, 3, 4, 5, 6. You can just see the names, and it goes up to like what I mean. We try to stop somewhere here whenever there is a coagulation understanding. But there are other factors like Hangman factors, Fitzgill factor, precalcitonin, heparin, protein C, and protein S. Nowadays, they have become more useful, and also antithrombin 3 for an advanced hemostasis there. Interestingly, coagulation, whenever there is a clotting started, so it goes from reverse process till here, fibrinogen formation, and then it comes to factor 13. So this is the way coagulation factor works, and these are the functions and the role of the coagulation uh, proteins, which are actually helping each other. So it is actually a very complex procedure. So this is we should always understand about few challenges what we may face with when we work. So hemostasis, as I understand in my experience, it is not about knowing a test and just doing it as a number. It is very tedious because we are not giving numerical values just for to write in the report, but it is giving a functional essay for the body. It is more of functional essays than a numerical or a quantifying essays. So which can have a lot of effect, and we need to understand the challenges. So it is pre-analytical errors which are very important and crucial role in hemostasis, and that is why many of the coagulation tests doesn't work well because of certain challenges which we will see. When do we try to do the test? Because it is always a question. People just cannot write a coagulation test because it need to have certain background of a problem. And then after that, what type of essays are we doing? Are there any recommendations for any specifications and interpretation? What type of technology? We all know hematology, okay? We have hematology analyzers, we have light, we have laser and things which is very simple in a technological angle. But here, do we have any specific understanding about the technology or reagents? Because this is a very crucial part of any hemostasis lab, or when you work, we should be having a thorough knowledge of reagents when we are doing in testing. And of course, the another medically important part is the knowledge about anticoagulant and their impact on different tests. If we have an understanding on these angles, maybe we can try and simplify our understanding in a hemostasis lab. So pre-analytical errors, I will not go one by one, but at least we should know about the different standardization methods what we monitor for pre-analytics. And most of the errors fall out of analytical phase, which we all know. So pre-analytical have a lot of interference and a great, challenge when we do some special tests. And I consider all coagulation or hemostasis tests as special. So they need to be treated special because even a small change in pre-analytic or any interference can change the entire result. So right from sample collection to sample handling and patient factors. So whenever we do a coagulation test, we should be very much aware about the different sample technique. And there is by BD we say something called as an order of draw. So in that order of draw, we should know what exactly we have been doing. Phlebotomy technique also is if you just keep the needle in your vein and try to just remove it for like next 2 minutes slowly and steadily. So coagulation starts in seconds. So then we have different sample volumes, sample tubes, and then very important is the logistic part whenever it is handled. And of course, the drug history, which we should not miss. So these are the few storage requirements, which is very important when you do a coagulation test, okay? Or whenever we have to identify something very important. So this is PT, PTT, or thrombin time and other assays. The stability of the plasma at 24 hours or 4 hours and 4. So we at room temperatures basically when we need to centrifuge and when we need to freeze. So we need to have a thorough understanding, and I think everybody follows certain guidelines for this. So general note on what exactly have to be done when we are dealing more with this. So we have an understanding about formation of the samples, the testing times, and when should we do. So basically, we have to do a coagulation test sometime, especially for like a factor 5 and factor 8, so sample doesn't deteriorate. And how do we move it ahead? And some people keep the plasma for almost like 6 months, and that has to be for 70 degrees centigrade because sometime it can be used. This is the one important aspect in coagulation. Always try to have an understanding about the platelet poor plasma. So it is important because this is a procedure where you do a centrifugation and try to see whether the platelets are out of the plasma. Because if there are platelet in the plasma and you're doing a test, the platelet gets activated and they will reduce the timing because they will start producing thrombosis activity very faster. So we should know the platelets have been removed, and there is a procedure of removing the platelet, and there are certain SOPs which are followed. And we also do a platelet poor plasma testing on a cell counter where the recommended one is you should have less than 5,000 count of the platelet when you are having a platelet poor plasma. And it is very important to have this because they contain platelet factor 4. They also contain phospholipid and they also contain proteases, which are going to affect the test for von Willebrand if you're trying to do. If there is a phospholipid not removed, it will affect the lupus test. So sensitivity of doing a platelet poor plasma in coagulation testing because the platelet have a very much of an interference. So that should be understood. The another interference is by hemolysis, what we say HIL index, hemolysis, icteric, and lipemia. So we do have certain analyzer nowadays, and the sheet also comes with an information that we should not do testing in some of the conditions. So for to check for hemolysis, APTT and D dimer should never be done if your sample is hemolyzed. Uh, but other also I will try not to use it because it may have an effect. These are certain ICSS recommendations for blood sample coagulation testing in for HIL. So hemolysis, icterus, and lipemia. You can still in lipemia you can do a centrifugation, remove the lipid, but when you want to do some lupus testing or any advanced testing, try and avoid because phospholipids and have a very high and impactful role in the entire coagulation. They will interfere with the coagulation testing. So these are certain pre-analytics. I'll not go too much into detail. Maybe you may already have this understanding and the consequences of having a pre-analytical error. These are different errors, and this is the consequences what you can see on when you have done the testing. So in some cases you have a high. In some cases you will have a shortened PT or APTT time, and this is due to inadequate techniques what we have. So just imagine even people when trying a tourniquet can also elevate von Willebrand factor and factor 8. So this is also to be knowledgeably exchanged with the phlebotomy department or the nursing department when they are doing a collection for these tests, because as I said, coagulation test is sensitive in its all manner, right from its testing to the patient problem of having some medicines or drugs. Now coming to why there is a need. Basically, we all know when we try to see, okay, if and interestingly, we don't get too much of coagulation test as we get CBCs. Why it is so? Because we need to understand the background of doing the test. So coagulation assays, basically they are functional bioassays, and as I said, they are not only the numbers, but they also give a functional assessment of the body's hemodynamic stability or equilibrium. So coagulation techniques are also used in mixing test, which I will come to it, wherein there are certain emergencies which can be identified. So these are the different type of tests what we see in coagulation. There are screening tests mostly for preoperatively. I believe many still do BTCT, but I think it should be obsolete because it is doesn't have a proper standards of doing. There would be errors in interpretations and in error even in doing it because it is not a simple test to perform also if we go by books. Then we have diagnostic tests where we try to identify bleeding or thrombotic disorders. Monitoring, which is again a very common, it takes around, say, I'll say 80% of the time. We do testing when the patient is on treatment. More on the anticoagulation therapy like heparin in intensive care, or patient on oral anticoagulants when they are having aspirin or when they are having warfarin. So these are very important. Certain experimental test, and then you can do a lot of molecular testing or genetic testing in certain conditions when there is absence of some issues. So this is a chart which can give you a full understanding about what are you dealing with. If you are starting your test with routine PT or APTT, okay. So if it is normal, stop. Normal when you are sure it is normal there is no interference, there is nothing on pre-analytical or any other angle. When it is normal, when PT is normal and prolonged, we have different set of analysis. When there is PT prolonged and PTT normal, you have a different analysis. You can do a mixing study to understand what exactly are we dealing with. And both prolonged, we have a complete arena of different problems. So these are the testing which are suggested in different type of situations. Right from a simple test like PT, APTT, you can reach doing factor 8, factor 9, factor 11, sometimes lupus, sometimes anti-factor 10A activity and lupuses. So just one test of PT and APTT can give a lot of understanding about a patient's coagulation parameters, and this screen or this chart could be very useful. So this is
Dr.
a mixing
Prakash,
study. Yeah,
I'm
sorry.
sorry, you still have around 5 minutes
Okay,
left. Yeah.
okay. This will finish in just 2 minutes, not more. Okay.
Okay.
So we have pre-surgical screening and the lupus test, which I think everybody knows about PT and APTT prolongation with just a simple test. These are few recommendations which are there: ISTH, ICSH, and we should always follow certain testing methods. If you are doing lupus, then be very careful of doing the lupus test with the mixing studies, because we also sometimes miss about circulating antibodies, which can be like acting like inhibitors, and we should know about the inhibitors on the lupus. So choices of the technology, there are a lot of different choices: clot-based assays, aggregation, chromogenic, and this. Every lab in the world is today stuck here. We are doing clot-based coagulation assays most of the time, where PT and APTT is there. I'll just take few seconds on this, because whenever you choose to start a coagulation testing or hemostasis, please try to look on the thromboblast, the tissue factors. So PT reagents are very sensitive for factors. Composition of phospholipid, are they liquid or recombinant? So this is a journal, again from Journal of Thrombosis and Hemostasis. This gives you a idea about how phospholipid content can on thromboplastin have an effect on your testing and validations. This again a chart which is important. You can use it for yourself, because whenever you have a test, patient is on treatment, you can think about what type of test to be done to understand. There is a factor 10 inhibitors, you have heparin, you have direct thrombin inhibitors. So where in the coagulation they are going to affect. When you have warfarin, we do a lot of PT and APTT because of its pathway, its effect on intrinsic as well as a bit on extrinsic pathway. So understanding about anticoagulant is very important. This is one of the chart which I could get it, which is very important, on what could be problem in intrinsic and what could be problem in extrinsic. So I got to her that the everything comes down an arrow towards thrombin. So whether it is common pathway or non-common pathway. This is a list of drugs which are very common, which have an effect on the routine testing. So these are the few tests which we should understand about. This is the technology part: clotting assist, turbidimetric, chromogenic. This is the screening and the monitoring test in the coagulation. If we have an understanding about the reagents, the technology, the things becomes much more easier. So these are few points to remember on this: understanding the coagulation disorder, need for the test, type of the test, understanding and variables, knowing the reagent is very, very important. Also the technology, they should be in sync with each other. Follow all the recommended guidelines, which are keep on changing in hemostasis a lot. The problem of the anticoagulants, we should have the details of anticoagulant and its effect and interpretations and the results. So here I finished for thrombosis, or say hemostasis. Now finally coming to the interesting part, which is the role of
Okay.
platelet parameter and a few case studies. Okay. So yeah, this is my first case study. If you can see, uh, so this is the case coming from the reactive thrombocytopenia and platelet indices. I have put the understanding about the case and the first level itself. So I have we were trying to understand platelet indices in dengue patient and predicting the severity of the disease and the outcome and recovery. So this was one of the case study which we did around 50 dengue cases in India long back, and we tried to follow up to 15 cases for their trend or any pattern, if there is any change in the platelet parameters coming in cases of dengue. And I am showing 8 follow-up cases for this presentation. So this is a simple basic platelet indices in dengue patients. So this is an inclusion criteria. If you want to perform or if you want to do a simple short analysis, you can do that. So these are the inclusion criteria. I used NS1, I used IgM, and the samples were processed on UMISN H500, which is a mid-range basic 5-part analyzer from Horiba. Patients which were excluded were negative for dengue. Basically, I tried to see the positive dengue cases and their effect. And the other causes of thrombocytopenia we excluded because we didn't want it to classify here right now. And samples which were not processed, of course, because there are other machines also. These are the indices which were into consideration. We consider PCT, MPV, PDW, PLCC, and PLCR. The focus on these indices. So these are the results coming from the dengue patients. So these are the number of 15 cases, as I told. This is the platelet grid, MPV, PDW, PLCC, and PLCR, which is coming from the dengue positive cases. And you can see the platelet count is towards the lower side. And if you can also see, there is a change in MPV and PDW in some cases. Okay. This is the follow-up data of the 8 patients, what I mentioned to you. So we took, this is patient 1, 2, 3, 4, 5, 6, 7, 8. And these are different days of their analysis. And I have a chart to show. This is just a table formation. So these are the platelet count, platelet grid, MPV, PDW, PLCC, PLCR, because these are all the basic indices available on the cell counter on UMISN 500. And you can see the changes happening just here also. Like from day 1, the platelet count is 91 for patient 1. And day 7, it is 164. If you can see the MPV changes and the PDW as a marker of anisocytosis, PLCC and PLCR also changing in these situations. So this is a graphical representation of all of these, actually 8 patients all put together. I'm sorry for the blurry slide, but if you can see, this is patient number 1, and day 1, day 4, day 7, the changes, So this is the red line is the MPV, the blue one is the platelet, and the green one is the PLCR. So even if I see all the patients who are under dengue, you can see the trend of PLCR, the rising and the falling of PLCR, and the increase of the platelets. So what exactly was the inference on this case study? What we did for the follow-up cases is basically we could see that PLCR is showing a trend to rise, which indicates the presence of larger and more platelets in the bloodstreams, in the blood count. So the plot here for all these patients, if you can see, it is showing a clear inverse relation between the platelet and the other 2 parameters, which is MPV and PLCR. So there is an inverse relation between those 2 parameters. And probably whenever you have PLCR in your system, you can probably see this is a case of reactive thrombocytopenia, that means peripheral destruction. So this is giving you an understanding about body's physiological response of recovery to the conditions affecting the platelet levels. So whenever the platelet count is down or dropped, we can see the rise of PLCR. It's an inversion of the ratio. So this is a follow-up case on the dengue, and basically we try to even presented this in our Indian pathology forum, and it was very well appreciated. And it is said that platelet indices should be particularly can become helpful in follow-up patients where these indices can be compared, because they will change on daily basis. They will change as per the treatment and analysis. And these are few of the cases which you can go and visit our website on Horiba. That now we have developed something called as dengue flag also in our new systems of 500 and 550, where whenever there is a dengue high, you can see there is a dengue flag, is a query, and there is a dengue scoring also, which is in the red. You have malaria and dengue, because in India we get malaria and dengue together in most of the time in the rainy season. And we have this is a card-based analysis of NS1. So NS1 test is basically something which where you don't have a very low platelet count. but the instrument is trying to give you an understanding on dengue flag. Similarly, this is dengue IgM positive case where it is an older machine where you can see there is platelet is getting dropped and PLCC and PLC are trying to rise. So these are the indices which can be very useful whenever you see a star mark on the platelet when you have a day case of dengue. And on WBC, you can see there is a bit of rise on atypical cells where we see the reactive lymphocytes coming into the picture. So all this information is giving about the dengue and the platelet indices, which are very important to understand. If you see there is no problem with the red blood cells at all, so there is no interference of the microcyte, but still there is a mark on your platelet. So here platelet is changing, low platelet grid. MPV may be starting rising. If you see PDW values increase, it is going on a higher side, and the PLCR and PLCC is also as a doubt. That means there is a change in the platelet count happening.
Okay,
So
thank you,
that
Dr.
was
Prakas.
yeah.
The time is up, so
Okay.
maybe we continue to Q&A session.
Oh yeah. So can I finish this just in a minute?
Okay, just maybe I give you 3 minutes.
Okay. Thank you so
Okay.
much. Because it will be not good if I don't conclude with thrombotic case, the other coagulation case. So this is again hyperdestructive thrombocytopenia. This is rise and fall of large platelet fraction. We have an LPF in our big system. So it is basically it is a case of consumptive coagulopathy, because we all know in snake bite we get something called as consumptive coagulopathy where the platelets are utilized too much along with the clotting factors and thing. So this is she is 27-year-old female. She is a case of snake bite. This we followed up this case to understand the role in predicting severity of the disease outcome and recovering. How a cell counter can be useful in giving an understanding about patient criticality and as well as the prognosis on a cell counter. So we used the case was on our high-end system called as UGM 2500, which have a capacity and capability of analyzing large platelet fraction, which is on high end. Okay. So basically, as we spoke about this, so I will go by case analysis. So she was admitted on 8th of April. We didn't know it that she is a snake bite. Then we started following it up later on. So whenever we do a large platelet fraction analysis, we have to change the mode of the patient. There is a CBC mode and there is an optical platelet mode. So you cannot get large platelet fraction on CBC mode, but we do get platelet, MPV, platelet crit, PDW, PLCC, and PLCR. If you can see only these factors, they are also changing a lot whenever the platelet count is less. So PCT has gone down, PDW has increased, even PLCR is increasing. This is just on day 2 of admission. And this is when we also started following it up on large platelet fraction. So when we do large platelet fraction, we also get optical platelet. So there is no change in impedance and optical. There is no other interference from microcytes or any of the other cells. You can see there is a clear differentiation between RBCs and platelet. So this is on 9th of April. This is again the following it up from 11th of April, 12th of April. There is, if you can see, platelet is still less, but can you see the PLCR? It is getting increasing day by day. The machine has started giving an idea about large platelet. So interestingly, I'm not showing you any microscopy slides, which is coming from peripheral smear. But if we can see, the machine is giving an idea about everything. And this is the optical platelet mode, where the LPF, which was on 9th, was 7.9. Now it is increased to 24. So that means the large platelets are coming into the picture. So this large platelet, if you can see, platelet I is 35, impedance, MPV increase, PDW, if you can see, it is very much of an increase. Okay, now if you can see that it is come to 30, and it is PLCR is increased and LPF is also increased. Optical platelet is still 36. The platelet count is still low, but the instrument is trying to pick the large platelet fractions. Again on 12th of April, from 11th to 12th, the LPF is trying to be stabilized up to 23 and PLCR rising. So this feature was happening till the time we got an idea when she was discharged. So this is 9th of May. It was a long stay of her in the hospital. On 9th of May, if you can see, the platelet count is 152, still MPV on a higher side. PDW still, because machine is trying to produce some platelet. TLCR is coming to stability. And if you can see, our LPF is come to normal because the reference range of LPF is 2 to 12, and it is stabilized with the stability on the platelet counts. So this is the rising and the falling. And if you can see the histograms on both the sides, the platelet, the alarms, they say there is a large platelet and which is getting correlated with your PTW as well as PLCRs in your progressive angle. So a word about snake bite. Whenever you have a snake bite, the problem is the toxin induced. You have a cardiotoxin or you have a vasculotoxic. So when you have a vasculotoxic snake, it will actually cause you consumptive coagulopathy, which is nothing but, as we say, microangiopathic hemolytic anemias. You have cystocytes, you have NRBCs, but you don't see any polychromasia or anything on the field, but you see very few platelets. So we should know the pathology behind the platelet analysis or anything. This is a word about microangiopathic hemolytic anemia, different type, DIC, TTP, HUS, HELP, and drug induced. All of them have an association with the CVC parameters like platelet, hemoglobin, and NRBCs, along with the change in hemostasis. Okay. And this is the data from that case, right, from 8th of April to 9th of May. If you can see LPF, it was not done on day one, but when we started doing it, 6.1, 16.7, 24, 23, 15, 18, then it got stabilized on 9th of May when the patient was about to discharge. These are the platelet flags from the machine. This is the microscopic data which we got from the pathologist. They've started seeing cystocytes on day one, target cell neutrophilia, thrombocytopenia, NRBCs. So this was in match with the technical data. These are the coagulation parameters because it is a consumptive coagulopathy where platelet and as well as coagulation is changing. We can see the change in PT, APTT, and D dimer value. I specifically chose D dimer because if you can see, whenever the D dimer was high, even my LPF started rising from that day. You know, whenever D dimer was getting stabilized, my LPF was also getting stabilized. So they are also in sync with that means there is a problem in coagulation or in the background of the coagulation, and there is a change which can be seen on the platelet count. So this is a graphical representation of the same. Okay, and I'll just conclude on that because platelet count impedance, I means impedance, it is improving when the marrow is regenerating, and LPF and PLCR values are decreasing. If you can see, this is the trend of the patient. This is a single patient. All right. So this is a PLCR which is started rising. This is platelet. When the platelet is falling, PLCR started rising and LPF also rising. So LPF as well as PLCR both have done almost a similar type of job when the platelet count was dropping. Once platelet count became stable, they started coming to the normal state. So it's an inverse relation. So this is also demonstrated that the patient is given an idea about severe thrombocytopenia. And interestingly, patient was not transfused platelet. Yes, she was given a 1 or 2 pack of FFP, that is fresh frozen plasma, which only have coagulation factors, but not platelet. So because of this conveying the message to the intensive care that we are monitoring the platelet parameters on our system. So you don't give an additional platelet, transfusion. You can give a coagulation factor transfusion like FFP or cryoglobulins, which can be often used. So conclusion is any parameters can be utilized, and because platelet plays an important role in our hemostasis as well, so we should know. And this is the coagulation which is coming from the conclusion which is coming from our snake bite case. So again, I finish with this slide. We should understand the basic understanding of the platelet and from where it is coming. So thank you so much. Thank you so much for the time you had.
Okay. Thank you, Dr. Prakash. Very interesting lecture, Prakash. Okay, and the next, dear participant, ladies and gentlemen, we have gained the valuable insight from Dr. Prakash to this, and we learned that platelet indices such as MPV, for example, PDW, PLCR, LPF are not just technical parameter, but also important clinical tools to help differentiate the cause of thrombocytopenia and so on. And also Dr. Brakas also give us a lecture of hemostasis and along with the case from Dr. Brakas. Now we will move on the Q&A session. So please, ladies and gentlemen, if you have any question, please feel free to raise your hand or use the microphone provided. Okay, actually there is a question number one from Fahmi. Thank you for your presentation. I have a question. You said you said it before, there is platelet in MDS or myelodysplastic syndrome. Also, there is a giant platelet or megathrombocyte released to peripheral blood. In MDS, there is also a thrombocytopenia. So, how to differentiate giant platelet in thrombocytopenia cause of reactivity such as dengue, or this is a malignancy such as in MDS? Because as far as I know, giant platelet is not caused by young platelet. It is because apoptosis in the case of MDS. Thank you.
Okay, so very interesting question, and thank you so much, Dr. Fahmi. Both are different aspect. You know, when you speak about myelodysplasia, it is more of dysplastic changes. So the problem is, yes, cell counter will never understand the large platelet. Is it coming from MDS very quickly or from from the reactive thrombocytopenia? The only understanding with MDS is till date. It is like you see dysplastic changes in the bone marrow, okay, where you are having where you see micromegakaryocytes in the bone marrow examination. But when you want to see it on the smears, it is basically you will not find many large platelets. You will try to find more of a platelet size which is smaller. You can see a giant platelet, but it will be very occasional. So when you want to differentiate a giant platelet in a case of thrombocytopenia of reactivity, when I say reactivity, it is more of reactive infection like dengue or reactive infection like sepsis. On the peripheral smear, you will see a lot of, reticulocyte polychromatophilia. Here, as I say, microscope is our friend. It is not always the cell counter which is going to be there. So we see a lot of polychromasia on our cell. There is reticulocytosis or retic is high. We do a retic analysis. And also there will be a lot of like cystocytes or fragmented cells, which is not going to be the feature in myelodysplasia. So you will not see any features of or any features of, say, hemolytic component in MDS versus in your reactive conditions like dengue or any hemolytic anemias. So this is basically two different type of pathologies what we see. And in giant platelet, when we say a very giant or a macro thrombocytes, these are very these are these are not going to be getting counted so well easily also on a cell counter, because they will be getting counted on a red blood cell because of the size itself. So we may miss it on the cell counter, but it will be easy to see it on the smear. So to keep it very simple, when we have to differentiate a thrombocytopenia coming from, say, MDS, so we have to see it on the smear, and on the smear we will see other reasons of dysplasia on MDS, like there will be dysgranulopoiesis in, say, your WBC parameters. There will be less count, but a lot of dysplastic changes, nuclear changes happening in the WBCs, and we will also try to see some dyserythropoiesis like binucleated, RBCs or nucleated red blood cell, which are binucleated or trinucleated, which is not a feature of reactive thrombocytopenia or reactive thrombo whenever there is a recovery in a case of dengue or in a case of any infection.
Okay, thank you, Dr. Prakash. So we still need the smear to differentiate the.
Exactly. We
Yeah,
cannot.
yeah.
We have to. So whatever technology is there, I mean, we all are pathologists. We cannot live without a microscope. So that is a part and parcel.
Okay. Okay, Dr. Fahmi, are you satisfied with this answer?
Yes. Thank you, Dr. Prakash, for your answer.
Thank you.
Okay. Yeah. Second question from Dharmayanti. For PPT examination, whether all hemolysis sample will affect the result or if the degree of hemolysis is more than the minimum limit.
So if I understand PPT, it is APTT, right?
Yes.
Okay. Yeah. Partial thromboplastin time, right?
Yes, yes, yes.
Okay. Okay. So
APTT. Yeah.
in my experience, I reject all the samples of hemolysis coming for APTT. The reason is APTT is very sensitive. Even though there is always an interference which can be like less than say 1 gram of hemoglobin can be still utilized. But we have done this experiment. It is good for PT. If you ask me for prothrombin time, you can still use an hemolytic sample which is having an hemolysis of less than 1 gram, which is on your when you analyze on the machines. But for APTT, any degree of hemolysis should be avoided to do a PTT examination. Uh, the reason is it will have a bad interference coming from the platelet and basically from the platelet side. Whenever there is a breakage of or hemolysis, platelet factor 4 start coming in, and you will have a falsely high results of APTT, because it acts like it is PF4 is basically for heparin, so to act for an heparin to happen. So try and avoid as much as of hemolysis you can, and try, if you are reporting it as per the literature, try to convey it to have a new sample. Otherwise, result will not be so good on APTD. But on PT, yes, you can still do it, like less than 1 gram of hemoglobin is still a possibility what you can see.
Okay. Thank you, Dr. Prakash. It's very clear.
Yeah.
Okay. And the next is, dear all participants, if you have a question, it's better you can ask directly to Dr. Prakash. So please feel free to use your microphone profile. Okay. Is there any question for from participant, please? Okay. Okay. This is a chat from another question,
Yeah.
Dr. Prakash, from DY. I don't know why. Thank you for your lecture. I would like to ask, in summary, how we can confidently predict thrombocytopenia is derived from platelet index only?
Mhm.
Yes.
So yes, we can, because I showed some literatures where platelet indices have, and I showed a chart of the platelet indices where you have an hypodestructive bone marrow versus an hyperdestructive bone marrow. So a use of platelet count, use of MPV, use of platelet crit, and use of your platelet large cell ratio, we can fairly describe a differentiation between predicted thrombocytopenia coming from dengue versus any other. There would be, I think in my presentation, there was one slide which was showing all the platelet indices which are common to dengue and to other conditions. So we can fairly do that, but you need to do a lot of analysis on dengue samples, because there could be an overlap. But MPV, PDW, PLCR, they have a strong prediction and indicator for dengue than others.
Okay. Thank you, Dr. Prakash. It's very clear. So, dear participant, is there any question? Please raise your hand or using your mic to ask to Dr. Prakash.
So I can see one from the chat, I guess.
Okay.
The question is on hemostasis examination. What is the suggested hemostasis examination to follow for patients in DOAC therapy? So the question is very interesting and very important for all of us. So I would suggest to keep the testing very simple, PT and APTT. Uh, PT is something which is very important for DOAC therapies, as we all try to do it from, say, first of all, upon INR of the patients where the therapeutic monitoring range has to be there. But there are many new DOACs which have come into, into the market nowadays or from the pharma industry. So nowadays we also try to do something called as an anti-factor 10A if there is an effect directly on the heparin like drugs. Okay. So if you want to have a good understanding on DOAC therapy monitoring, so PTT is still the first one. And the second important becomes the anti-factor 10 activity.
Okay, thank you, Dr. Prakash. Because the time is limited, Dr. Prakash, we have only until 15 minutes for Q&A session. So
Okay.
in the next session will be a review from our teacher, from the Professor Dr. Usi Sukarini, clinical pathologist.
Okay.
Okay. Please, Professor Dr. Usi Sukarini. It's my honor to introduce Professor Dr. Usi Sukarini. She is a clinical pathologist from Universitas Gadjah Mada. Professor Usi earned her medical degree for Faculty of Medicine, UGM, in 1985 and completed his specialization in clinical pathology at UGM in 1996. So she later pursued a master degree in clinical epidemiology and biostatistics at UGM in 2001, followed by advanced consultant training in hematology and blood bank transfusion medicine in 2011. She was also awarded from doctoral degree at UGM in 2017. Now, currently, Professor Usi Sukarini serves as faculty member at Department of Clinical Pathology and Laboratory Medicine, Faculty of Medicine, Universitas Gadjah Mada as a consultant clinical pathologist, especially in hematology, and we are privileged to have her with us today to share her expertise and review from the topic discussed. Please join me in warmly welcoming Professor Usrini. Time is yours, Professor Usi.
Thank you, Dr. Janki. You hear me?
Yes,
You
clear,
hear me?
Professor.
Okay. Okay. Good morning, Dr. Prakash.
Very good.
Yeah, we are happy to have you here in the webinar, and thank you for your excellent presentations. May I share? Maybe Panitia can share my presentation. Yeah. Okay. The first of all, I want to comment about the second presentation of Dr. Prakash. Yeah, there are three. We already know that there are three process in a laboratory setting. These are pre-analytical phase, analytical, and post-analytical phase. Actually, the pre-analytical phase consists of two phases. This is there are pre-analytical phase. Consists of the test request. And the ward and the clinician should be order the test, appropriate test, and then also giving the patient and specimen identification. Also, the nurse maybe doing the blood drawing, the appropriate blood drawing, and then the transposition to sample of laboratory. But here in the pre-analytical phase, especially for in a laboratory setting, is our responsibility. Refers to pipetting, dilution, and then aliquoting, centrifugation, and so on. Yeah. And then because of the many pitfalls in hemostasis testing point of view, like because of low stability of the coagulation factors, also the calcium dependency, and then maybe the properties of the platelets, yeah, and then availability of the many coagulation factors like factor 5 and factor 8 is they have the low stability. So they have many pitfalls here, and we have to aware about this, yeah. And then in analytical phase, depend on the technology and also the reagents we use, yeah. And then we also know the effect of the anticoagulant therapy. And then move to post-analytical phase, also consists of two phases. The first is post-analytical phase, especially in laboratory setting. There are verification of results. Yeah, we have to know the plausibility of the result of the laboratory results related to the knowledge, our knowledge. Yeah, and then how to communicating the result to clinicians. And then the second is post-analytical phase. This is a clinical point of view. How to clinician make a decision, yeah, and then apply to their therapy, yeah. So in analytical, pre-analytical, analytical, and post-analytical, we have to have the recommendation, guideline, interpretations to do the right things, yeah. And then many Dr. Prakash already mentioned about the many hemostasis testing, yeah. And your slide, next slide, please. Yeah, Dr. Prakash has mentioned about the test, yeah. I copied your slide, and this, especially this slide.
It's okay.
Yeah. We in Sarjito Hospital, we perform the green one. Yeah, the green one.
Okay.
Yeah. We expected to we can perform the others tests like antifactor 10A, lupus anticoagulant, and maybe other factors. But because until now we sometimes we face the unfinished unfinished diagnose, especially
Yes, yes, I know.
SSC. Yeah. Okay. Next slide, please. Yeah, especially in thrombocytopenia, can occur in various conditions. One of which is due to the increased destruction or decreased production. Yeah, this need to be differentiated by a platelet profile examination, like Dr. Prakash mentioned. And many laboratory still using impedance methods, yeah, measuring the volume or platelet size. But sometimes we come up with pseudothrombocytosis because of erythrocyte fragmentation. The cell are counted by the platelets, yeah. So we have the pseudothrombocytosis. And also, if we detect the increase of platelet size, we should remember that this is a sign of thrombogenicity. Yeah, refers to platelet recovery, and especially is to compensate for thrombocytopenia and peripheral circulation. Please, next slide. Yeah. And the platelet thrombogenicity is shown by the large size of the young platelets. Yeah, we can see that Dr. Bras also mentioned that the young platelets is a new release by the bone marrow. Yeah, and it is different from the immature platelets because the immature platelets is, for example, is proplatelets or protrusion. But in other instrument, Dr. Prakash, they also mention the immature platelets. Maybe it's
Exactly.
similar
Yeah.
with the LPF, maybe, yeah, because they
Yeah.
also measure the RNA content. Yeah.
So it is basically the technology. It is nothing to do with the size, you know.
Yeah.
So we try to capture on fluorescence-free understanding because we try to capture on refractive indexing. So the refractive index of the density of the particular corpuscle will not change. It will be different from the other. So the near one is the RBC. So RBC index and the platelet index are different. So it is very interesting if we capture on refractive index technology rather than, because if I do a staining in by fluorescence, you know, so it can also capture if your sample is old, it is getting degenerated. So degenerated samples take additional dye or the additional chemical when you do an reticulocyte analysis by automation. So that is why there is a strong message given when you want to do immature platelet, what we say. First of all, the platelet cannot be immature in the peripheral blood. They are all mature to function, their properties. And if you have a lot of DNA fragments and everything, it will be a problem. So fragmented DNA, denatured DNA will also take up the fluorescence and they will interfere in your analysis. So that is why Horiba didn't wanted to use the fluorescent technology. So we combined the impedance and the optic together so that we give a almost 360-degree view of the cell to analyze, so that we avoid interference of the other like fragments like cystocytes or the fragments coming from even from WBCs, apoptotic cells. Because when you run a sample in the machine, it takes say around 180 or 100 microliter of sample, but it do analysis of around 10,000 to 20,000 cells, which we don't see. So machines are more sensitive in taking additional information, and we see the information on the microscopes. So first of all, I always say, and I think you all know Dr. Sukesh Nair also from CMC Vellore in India, who is one of our, a mentor also, who is helped in develop the large platelets for us. Always says you cannot have immaturity in platelets. And this is not the right term. If you want to say immature, so you have proplatelets or platelet protrusions, what you see in the bone marrow when there is a lot of changes happening. But in peripheral blood, you will not get them so easily. And immaturity is not a good sign for function. Interestingly, the large platelets or the young platelets, which are there in the peripheral blood, they are more reactive. They are more, helpful to do thrombosis. So they cannot be immature. So they are very good in their functions. So this is what I can say about it. So reticulated platelet, as I said, it is not biology. It is a technology. You add a dye, like we add methylene blue or silver staining dye for retic, to see.
Okay.
So it is just a dye. But platelets always have RNAs. They don't have any other content.
Okay, so the reticulous platelets is technical aspect point of view. You mean that like this?
Yes.
Yeah.
Yes. It is
Okay.
not biology. Biologically,
Okay.
platelets have RNA.
So the biology.
When the count decreases,
Hmm.
when the
Okay.
count decreases, so it becomes easier to because impedance cannot count all the large platelet. So it is like when the bone marrow is compensating, it produces more larger forms of platelets. Wherein in our traditional impedance technology, it is not getting counted, because of its limitation. So to count the large platelet, we try to identify some other technology. So one of the technology is reticulated platelet, and we are using large platelets fractions. So we don't use fluorescence to identify these platelets because it is a biophysical property. It is just the count which you want to get it.
Okay, so reticulated platelets is just subpopulation of young large
Exactly.
platelets, yeah?
Exactly.
Commonly young, and then the size is increased large
Yeah.
platelets, yeah.
Yeah.
Okay.
So that is why I shared you all the literature, because it is not my experiment. It is an
Yeah,
experiment
yeah. That's all
of
right.
many people. So you can read about it. It's a very interesting article to read.
Yeah, okay. Then I try to make the concept. Next, please. Yeah. Would you comment? Yeah. This is the normal platelets in the left side, and then the right side, the large platelets more than 4 to 7 or 8 micromilli. Yeah, secret more granules, and then after activation, aggregate faster. Yeah, it's large platelets and more rapid to aggregate, and then compare with the small one actually, and then this there's a young platelets. It's a large platelet population. You said that, and
Yes. So it is,
yeah.
It
And
is
then,
it is same. It is almost same, you say.
oh, okay.
So young platelets are usually large in size. What we see on on the microscope. Okay. So they are usually the large. So if you want to put this as a in the concept, so large platelet is equal to the young platelet most of the time, 90% of the time, and reticulated platelet is a subpopulation of the
Yeah,
young
young
platelet.
platelets.
Yes,
Also, so the large platelets similar with young platelets that can
exactly.
measure with and then measured by LPF.
Yes.
Okay. And
Yeah.
then reticulated platelets is just subpopulation of young large platelets.
Exactly. Because what happens, the young platelets can also be small in size, you know. So when you use a reticulated platelet, they only focus on large platelets with dense RNA. Okay, when you want to put a retic, the staining. But in LPF, we focus on all type of platelets, which are
Okay.
small, which are large. So that is why we are doing in optical channel. So in your platelet optical mode, you capture all the platelets what is available, which is coming in that fraction, as I showed you on the graph. Okay.
Okay, so the reticulate platelets is have more dense of RNA. Okay.
Yes.
Okay. Next, I have a second concept here.
Okay.
So is it? I think it's the A concept is more accurate, yeah, because
Yeah.
I revise that large platelets should be young platelets. Okay.
Exactly.
Okay. Next slide. Yeah. Okay. This we have discussed about the FBF. Yeah,
Right.
because the Noriba have the combination of methods, emission methods to measure the size and then the content of RNA with the platelet optical excitation, and we measure the refractive index like platelet ox. Yeah, and you have the LPF. Yeah.
Right.
And then next slide, we have the high, yeah. And then we measure all contact young platelets both with and without RNA. Is right.
Right. So
Okay.
we don't use any the dye. Basically, when we say the dye, it is the fluorescence, and like thiazole orange, we use it for streamlining all the cells to increase the density. So when during counting, but we don't stain them.
If the LPF measure the platelet without RNA,
Yes.
what does this mean? What does it mean?
So we don't count the RNA like you have the reticulated platelet. Okay.
Oh, okay.
With RNA is reticulated platelet. So when we count reticulated platelet which are dense in RNA, we will miss some of the platelets which are less RNA. Okay. So that is why that is why we, as in technology, we wanted all the type of young platelets to be counted. So if you see the literature, the young platelets are a combination of 90% of the time big size, large, and 10% which will be small size. So we count everything in large platelet fraction because everybody understand the large platelet faster than all the platelets.
Okay. Next, we have to finish take-home message. Blood profile review has not been widely used in interpreting laboratory results, especially in our setting, yeah, Dr. Prakash. Especially those related to thrombocytopenia, and it's necessary to differentiate to know the cause of thrombocytopenia between increased destruction or decreased production. Yeah, we can use the LPF for differentiate the kind of disease. Yeah. Thank you very much, Dr. Dani.
Thank you so much for this compilation in very short time, which is very commendable. That
Okay.
Thank
during
you.
the presentation,
Okay.
somebody has combined everything. I cannot do it so fast.
Okay. Thank you very much, Professor Dr. Usi Sukarini and Dr. Prakash. So, ladies and gentlemen, so as we come to the end of today's session, so we have learned very much from Professor Dr. Usi and Dr. Prakash. And in summary, For a long time, platelet assessment has often been limited to platelet count alone, but today we have learned that the extended parameters such as MPV, platelet distribution width, DV, PLCR, or LPF provide much greater value. These indices are not only technical parameters, but also powerful clinical tools to better understand thrombocytopenia and predict platelet recovery. So by integrating that into routine practice, not only platelet count, we can enhance diagnostic accuracy and improve patient management. So on behalf of the organizing committee, I would like to sincerely thank our distinguished speaker, Dr. Prakash, and all participants for your engagement. So please forgive us for any shortcoming or mistake during presentation. With that, I officially close today's seminar, and then the time I give back to MC. Thank you very much.
Terima kasih kepada Profesor Usi, Dr. Prakash, dan Dr. Dani atas diskusi dan pembahasannya yang sangat luar biasa. Tentunya ilmu dari beliau-beliau sangat berguna bagi kita semua dalam menghadapi berbagai kasus yang variatif di dunia patologi klinik dan kedokteran laboratorium, khususnya dalam bidang hemostasis. Semoga diskusi ini dapat memperluas khazanah keilmuan kita terkait hemostasis untuk membantu memberikan kebaikan dan manfaat bagi penegakan diagnosis dan kesembuhan pasien. Bapak Ibu dokter yang berbahagia, selanjutnya adalah pemberian cendera mata. Cendera mata telah diberikan oleh Kepala Departemen Patologi Klinik FK-KMK UGM, Dr. Tri Ratnaningsih MKes, Spesialis Patologi Klinik, Subspesialis KT Konsultan, Subspesialis Hematologi Klinik Konsultan, kepada Dr. Prakas Bakwanda Sufasya MBBS Dipet and Batch FCPS DNB. Bapak Ibu dokter yang berbahagia, acara selanjutnya adalah sesi foto bersama. Mohon Ibu agar mengaktifkan kamera dan memberikan senyum terbaiknya. Kita mulai untuk sesi foto bersama. Dimulai dari halaman 1. 1, 2, 3. Lalu halaman 2. 1, 2, 3. Halaman 3. 1, 2, 3. Dan terakhir halaman 4. 1, 2, 3. Baik, terima kasih Bapak Ibu dokter yang berbahagia yang telah berpartisipasi dalam acara sesi foto bersama. Tidak terasa kita sampai di penghujung acara. Kami ucapkan terima kasih banyak kepada para pembicara, guru kami, dan kepada seluruh Bapak Ibu dokter peserta guest lecture, Platelet, Maximizing the Potential, Simplifying Hemostasis in Your Lab. Saya, Cutrege Haldayana, mohon undur diri. Mohon maaf apabila ada salah kata. Sampai jumpa di kesempatan berikutnya dan terima kasih sekali lagi telah hadir di acara guest lecture Platelet Maximizing the Potential, Simplifying Hemostasis in Your Lab. Wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Waalaikumsalam warahmatullahi
Thank you, Dr. Prakash. Thank you, Dr. Usi,
wabarakatuh.
Dr. Dani, Dr. Rekia, all partisipan. Terima kasih banyak.